Cancer continues to be one of the leading causes of death in many populations, despite our improved ability to detect and diagnose it. The NIH projects that the numbers of cancer survivors will increase from 7.9 million survivors in 2022 to over 26 million in the year 2040. And so it is that our ability to combat cancer has significantly improved from the crude treatments of the early 1900s, but we still wonder when more cancers will be cured. We are still identifying unique pathways to how cancer develops, and we are fighting fiercely in labs around the world to find better ways to beat it. Countless labs filled with brilliant scientists are working to innovate current forms of treatment to increase their effectiveness and broaden the cancers they can target. In this season of Data for the People, we explore how two therapeutic modalities, radiotherapy and immunotherapy, are evolving to help us beat cancer.
My name is Rachel Payne. I'm a PhD candidate in the pharmacology program at Weill Cornell, and today I'll be presenting on the latest advances in radiation-based cancer imaging and treatment. So to tell you a little bit about me, I was raised in the state of Utah, over to the left side in the western United States. It's a really beautiful state, as you can see from this image here. This is the Oquirrh Mountain Range near my hometown of Tooele, Utah. I pursued my undergraduate degree in Salt Lake City at the University of Utah. And as you can see, once again, it's an absolutely beautiful area to live, and there are these gorgeous mountains encapsulating the city. At the University of Utah, I studied chemistry with minors in nuclear engineering and physics. And the reason why I'm emphasizing my minors is because they're essentially the reason why I am where I am today. Through the nuclear engineering program, I really came to appreciate the ways that radioactivity can be useful to us. And to make a terrible pun, I think it's super rad. I mean, just look how excited I am standing next to this radioactive hood. Clearly, there's something really neat about what's happening in there. I do want to take the chance to shout out Dr. Luther McDonald and Dr. Tara Maestrin in the nuclear engineering department, since without these folks, I really wouldn't be where I am today. After I received my bachelor's degree, I moved across the country to pursue my PhD. And as you can imagine, this was quite the change in environment, as the city background changed from mountains to skyscrapers. So right now, as a graduate student at Weill Cornell Medicine and Memorial Sloan Kettering, I'm currently interested in how we can use different types of radiation to treat cancer. And these are my two mentors, Dr. Jason Lewis and Dr. Kishore Pilarsetti, who are helping to guide my research and are genuinely just amazing human beings. So I want to start off this talk by asking, what comes to mind when you think of radioactivity or radiation? Maybe you might think of nuclear reactors or neon green toxic waste, or maybe you think about the way media commonly talks about radioactivity, from the hit Imagine Dragons song to maybe TV and movies like HBO's Chernobyl series and Oppenheimer. You might also think of superheroes like the Hulk and Spider-Man, who got their superpowers from radioactivity. And while these depictions of radioactivity are really fun to think about and to see, they don't give us an accurate understanding of what it actually is. In reality, radioactivity is the particle or wave emissions from an unstable atom. When an atom has too much charge, energy, or mass, it's considered to be unstable. We can think of an unstable atom as essentially being uncomfortable. Kind of like the feeling when you eat too much candy or drink too much coffee and you feel like you need to release the energy from all that sugar or caffeine. You feel like you're bouncing out of your seat and you need to go run the energy off. Essentially, this atom feels the same way. But instead of, running it off or releasing it, in order to become stable, the atom will emit a particle or a wave. And we call these emissions radioactivity or radiation. So we can find natural radioactivity in a variety of settings. We get some degree of radiation from unstable elements in outer space. The Earth's atmosphere protects us from a lot of cosmic radiation, but not all of it. We can also find radiation in naturally occurring minerals on Earth. Some of these minerals are required for biological processes inside our body, so we can also find some degree of radioactivity in there. And I want to emphasize that these types of naturally occurring radiation are entirely safe. If they weren't, humans couldn't survive on our planet. The relative safety of radiation depends on how much of it there is. We can use a unit called millisieverts, abbreviated as MSV, to express how much radiation we're being exposed to. The average radiation dose from natural sources is around 6.2 millisieverts per year, and this dose encompasses a wide variety of activities. For example, eating 100 grams of Brazil nuts delivers about 0.01 millisieverts of radiation from naturally occurring minerals including barium and radium. A transatlantic flight delivers a dose of 0.08 millisieverts of radiation, since we're closer to the cosmic radiation from outer space that I discussed before. 100 millisieverts is the lowest yearly dose at which radiation can cause cancer, so we typically try to stay below this limit in terms of medical and occupational exposure. We consider anything at or above 100 millisieverts per year to be the danger zone, essentially. This is where radiation can be really harmful. Radiation workers in the United States are limited to about half this dose, below 50 millisieverts of radiation exposure per year. And this annual dose is monitored by their employer. I'm considered a radiation worker, so I'm required to keep my dose below this limit. Medical diagnostic scans, including CT scans, typically are going to deliver about 10 millisieverts of dose, so patients are still receiving relatively safe doses of radiation for medical procedures like this. Unsafe radiation doses above 100 millisieverts typically come from exposure to some type of radiation accident or disaster, such as the Chernobyl or Fukushima reactor meltdowns. Some of the Chernobyl first responders received an estimated 6,000 millisieverts of radiation, and these individuals died within a month from their radiation dose. So even though we think about a toxic radiation dose as being something bad, radiation-induced death isn't always a bad thing. So in the next segment, I'm going to be talking about how damaging levels of radiation can be helpful, specifically in the context of cancer. For instance, when we have an uncontrolled or unusual growth of cells in the body, also known as cancer, radiation can be used to help get rid of these. Over time, we've actually become quite good at targeting radiation specifically to cancer cells without affecting the rest of the body. Radiation therapy combines a targeted drug with a radioactive atom that emits damaging particles so that we can kill cancer cells. In this case, radiation is useful. It's helping us get rid of disease. So, as you can see here, we have a radioactive drug. It's emitting particles, and it eventually ends up killing the cancer as part of those particle emissions. Another way radiation can be useful is for imaging specific parts of the body. This approach also involves using a targeted drug, but this time we attach a radioactive atom that gives off long-range waves, such as X-rays or gammas, that pass through the body. We're able to detect these waves using a radiation detector. As you can see here, the radioactive drug is targeted to the tumor and then emits long-range waves that are picked up by the radiation detector. And this is how we can find tumors within the body using radiation. So next, let's look at how radioactivity is used in medicine to diagnose and treat disease. In this presentation, we're specifically going to be looking at prostate cancer, since that's my area of expertise, and there are also some really cool drugs to look at. We're going to be asking the question, how do we use radiation imaging and treatment for prostate cancer? So, prostate cancer is the second most common cancer in men. When it's only located within the prostate, this form of cancer is highly treatable. We run into problems when the cancer spreads throughout the rest of the body or metastasizes. Only about 31% of men with metastatic prostate cancer survive for 5 years. We use radiation-based methods in a variety of ways to improve outcomes for these patients. So first and foremost, I'm going to be talking about how we use radiation to image where the cancer is located. For prostate cancer, we use something called SPECT imaging to look at cancer that's spread to the bones. SPECT stands for single photon emission computed tomography. And to break that down a little bit, single photon emission is another way to say gamma ray emission, which is the type of radiation we're detecting. Computed tomography is a three-dimensional map created by a computer. SPECT scans detect gamma rays, which are the highest form energy of electromagnetic waves. By detecting these gamma rays with a specialized detector, we can see otherwise undetectable tumors on the bones, which can help guide future treatments. If we're looking at the image on the left, this is a prostate cancer patient that was injected with a SPECT imaging agent called osteolyte, which is used to detect tumors on the bones. The arrows here are pointing to the locations where the patient has tumors. Even though this imaging method is really helpful, the problem with SPECT is that it doesn't have very high resolution. So we might see tumors that don't exist, otherwise known as false positives, or we might miss tumors that do exist, otherwise known as false negatives. So the question arises, how do we remedy this and image tumors more accurately? This is where another radiation-based imaging method comes in handy. PET imaging is a technique that's been around since the 1980s, and right now it's one of the highest resolution ways to detect specific types of cancer. We can achieve significantly higher resolution with PET compared to SPECT, which means we can see smaller tumors. You can see in the image on the left side that the SPECT imaging of these tumors is really blurry, whereas in the PET imaging we can see very small tumors very clearly. The PET imaging agent that's used in the picture here is a drug called Locomets, which targets a protein called PSMA in prostate cancer tumors. PET imaging with Locomets has had a significant impact on how we treat late-stage cases of prostate cancer. After Locomets imaging, about 50% of patients are changed to a different treatment plan because the doctor realizes that they have more or fewer tumors than they initially thought. So this form of imaging is super impactful to determine how to treat each patient's cancer. To explain why PET imaging has much higher resolution compared to SPECT, we need to understand how it works. PET stands for positron emission tomography. Positron is the type of particle emitted from the radioactive atom, and it's essentially an electron that has a positive charge. By detecting this emission, we're able to develop a three-dimensional map. So, funny enough, we aren't able to detect the positron itself because it doesn't travel very far, so it never leaves the body. Instead, we detect two gamma rays that come from a positron in a process called positron annihilation. So shortly after it's emitted, the positron will eventually crash into an electron. And then this combined positron and electron will form two gamma rays traveling in opposite directions. And so in PET imaging, we're able to detect these gamma rays using a circular radiation detector. And from there, we can determine the source of the radiation, or in this case, where the disease is located. We're able to see more of a disease state using PET imaging as opposed to SPECT imaging because we're able to detect two gamma rays instead of one. To put it in another phraseology, we're able to triangulate the signal a lot better. So that's why when you go in for a PET scan, it looks kind of like a tunnel. That's the circular gamma ray detector. Once we understand where the patient's tumors are located using SPECT imaging, PET imaging, or other diagnostic methods, we need to figure out how to treat it. So for the next segment, we're going to be looking at targeted radiation treatments for prostate cancer. One drug that's particularly useful for metastatic prostate cancer is a drug called Pluvicto. This medication targets a protein called PSMA and delivers a dose of beta particles that kill the cancer cells. Beta therapy uses electrons to kill cells, which is considered a type of particle emission. This form of therapy has been effective in about 40 to 60% of cases, and it provides an average survival benefit of 4 months for these patients. And even though that seems like it might be a very small benefit, you have to remember that this form of cancer is highly aggressive, and patients at this stage often have already exhausted every other treatment option at this point. So to be able to give a patient 4 more months of life at this stage is huge. You can see from the image on the left side that some of the treatment responses we're getting in these patients is incredible. This patient had lots of tumors throughout their body, especially in their bones. And after 2 treatments with Pluvicto, we can see the tumors have essentially disappeared. We're seeing a really fantastic response to this drug overall, especially for late-stage tumors that have spread all over the body. In general, Pluvicto has been a really great addition to the treatments we have for late-stage prostate cancer. Unfortunately, as happens with a lot of different cancer treatments, Pluvicto doesn't work in every case. About 50% of patients don't respond to this type of treatment. This means that even after they receive the treatment, the cancer is going to keep spreading and their tumors are going to keep growing larger. For instance, the patient pictured here was treated with 2 rounds of Pluvicto and had a severe increase in the amount of tumors, especially in their abdomen. Luckily, beta particles aren't the only type of damaging radiation we can use, as I'm going to explore further on the next slide. So when we use the same targeting drug but replace the beta emitting atom with an alpha particle emitting atom, such as 225-actinium, we see a significantly enhanced response. In this particular case, the tumors have been cleared away, and we can see how much more effective the alpha particles were compared to the beta. This is because alpha particles are more than 7,000 times the size of beta particles. If a beta particle was the size of an ant, an alpha particle would be the size of the Statue of Liberty. So with such a large size difference, it's really easy to imagine how much more damage an alpha particle could induce and why it's so much more efficacious in these cases that are resistant to beta therapy. One problem we're experiencing using alpha particles that we're still trying to address is the large amount of damage they can induce in healthy tissues. Treating prostate cancer with 225-actinium PSMA can cause a variety of negative side effects, including damage to salivary glands, kidney damage, fatigue, nausea, and vomiting. The reason why is because targeted drugs aren't perfect, and sometimes they go places we don't want them to. Pluvicto and 225-actinium PSMA work by targeting a protein called PSMA. For patients selected to receive this therapy, the level of PSMA in their tumors is really high, so we're able to get a lot of drug into tumors to kill cancer cells. Unfortunately, our bodies also express some PSMA in the kidneys and in the salivary glands, which means the drug will also kill cells in these healthy tissues. This can result in some really undesirable side effects for patients, like the inability to eat or swallow, and in some cases, it can cause kidney damage. For example, as we see on the left side, this patient received a cycle of 225-actinium PSMA treatment. This is what their salivary glands looked like before therapy. After therapy, we can see their salivary glands are significantly reduced, so this patient probably is unable to produce saliva, and it's probably really hard for them to eat or swallow. So right now, researchers are actively working to address this problem by considering combined beta and alpha therapy, using ice packs to reduce healthy tissue uptake, and changing the way the drug is formulated. All in all, there are a lot of different ways we can use radiation to image and treat prostate cancer. SPECT is a relatively cheap and available form of imaging, however, it suffers from low resolution. PET imaging is a strong alternative despite its high cost and radiation dose, since it's able to deliver remarkable resolution and specificity. On the treatment side, we're able to use both beta and alpha particles to induce damage in tumors. Beta therapy is more widely available and is less toxic. However, in some cases, it may not be as effective. On the other hand, alpha therapy is highly effective, but it suffers from low availability and high toxicity. Overall, effective treatment often requires a combination of these approaches. Doctors and scientific researchers are still working together to develop more specific treatments tailored to each patient. So kind of to end this presentation, I want to emphasize that medical uses for radiation are constantly expanding and improving. Radiation-based imaging and therapy have huge potential to shift the paradigm of therapy strategies and improve outcomes for patients. This is still a growing field, and it's going to be really exciting to see how it evolves in the future. Thank you.
Hi, my name is Zahin Qayyum. I am here representing Data for the People at the Rockefeller University. I am here with Rachel Payne and Akanksha Kapoor, who are both rising scientists studying cancer therapies. Today, me and Akanksha will be going into a Q&A session with Rachel to talk a little bit more about radiotherapy. So first off, I want to start off with, which forms of cancer is this therapy used for?
Essentially all of them, especially when we're talking about external beam radiotherapy. You can target any section of the body.
What other forms of treatments are available, and how does this therapy compare? When would you use this therapy instead of another form of available treatment?
So there's a lot of different available treatments for cancer, including chemotherapy, hormone therapy, immunotherapy. And when radiotherapy is used, it's usually in later stage cases, at least from what we've seen so far. There are a few promising results showing it might be used in earlier stage disease, but primarily it's reserved for late stage cancers.
What are the risks involved with this type of treatment?
For radiotherapy, we are primarily looking at radiation poisoning effects. So nausea, vomiting, loss of appetite, fatigue, any of those would be side effects.
How are researchers addressing the long-term side effects this therapy has on a patient's overall health?
So there's a variety of methods researchers have been using. We can use combination therapy, so we can use radiotherapy in combination with immunotherapy, chemotherapy, and since there's such a broad range of radiotherapies available, some are more toxic than others. So we can also combine different radiotherapies in order to mitigate toxicities. One other approach that we've been using recently is changing the drug formulation so that essentially the radioactivity isn't reaching those healthier areas of the body and is only reaching the tumors.
What are the biggest challenges facing the field of this therapy, and how are scientists working to overcome them?
I think in large part, if we're talking especially about targeted radiotherapy, toxicity is limiting. So you can't treat a patient in early stage disease with a targeted radiotherapy because the risks outweigh the benefits. Essentially, this patient is going to experience really severe effects from the radiation poisoning, and it's not going to be beneficial to their treatment strategy. So I think toxicity is the primary issue we're dealing with in radiotherapy.
Since radiation isn't good for our body, why is radiotherapy a viable solution to cure or manage cancer?
I guess to put it bluntly, cancer is bad. We don't want cancer in our body, and radiation can kill things. Radiation is quite good at killing things. And so humans are pretty intelligent, and so we found ways to target that radiation specifically to areas of the body that we don't want, like tumors. So yeah, that's why radiation is helpful. It kills the cancer cell.
What are the latest research findings that show promise for this therapy in improving cancer survival rates?
So I think the biggest strides we've made are primarily in alpha therapy. There's, to my knowledge, there's currently only one FDA-approved alpha therapy. It's a radium drug. It's used for bone metastases, and it's actually not used to get rid of it. It's kind of used in very late stage disease to mitigate pain that these patients are experiencing. So I think alpha therapy is going to be the next big thing, specifically because alpha particles don't travel very far in the body. So we're able to target very, very small tumors. So I'm really hopeful to see what's coming next in alpha therapy.
I'd like to thank Akanksha and Rachel for presenting their talks today, and I'd also like to thank Data for the People and the Rockefeller University for letting us host this event.